Hello, this is Emergency 3 on sepsis and septic shock presented by the SchrDbb with reference Harrison Internal Medicine by Dennis Caspar AR. So we're going to visualize sepsis and septic shock. So the definition, what is sepsis? So sepsis consists of two or more elements in this table, in this list. So the first thing is fever. So fever, if you have fever of temperature of greater than 38 degrees Celsius, that's oral temperature, is going to be said to be in case of sepsis. Or you have a temperature of less than 36 degrees Celsius. You have tachypnea of greater than 24 breaths per minute. You have tachycardia of greater than 90 beats per minute, and you have leukocytosis of greater than 12,000 or less than 4,000. So all these are the characteristics of sepsis. So now we have severe sepsis. So what is severe sepsis? It is a harmful systemic disorder with a proven microbial etiology. So septic shock now is when you have sepsis with hypotension. That is, the arterial blood pressure is less than 90 meters of mercury or 40 below the patient normal blood pressure. If you have a blood pressure of 40 below the patient's normal blood pressure, is going to be set as septic shock. So now the next thing is etiology. So what are the etiologies of septic shock? The etiology, we have blood culture is going to be positive in 20 to 40%. So it means that in 40 to 60% of cases is not going to be positive. So if infected patient in the intensive care unit, so what are the major microorganisms? You have gram-negative bacteria are going to be involved, such as Pseudomonas species. You have Escherichia coli. You can have also gram-positive bacteria involved in sepsis, such as Staphylococcus aureus, and you have fungi such as Candida. So now the next one now is the pathophysiology of shock. So when you have pathophysiology, you are going to have local and systemic host responses. So what are the problems involved here? You have host responses. You are going to have microbial molecules such as lipopolysaccharide, lipoproteins, and double-stranded DNA are going to cause the triggering of the release of cytokines. And when cytokines are going to be released, it's now going to make the blood flow and the migration into the blood flow, migration of neutrophil into the tissues more favorable due to vascular permeability. Now the next thing that you're going to visualize is that many local and systemic control of cellular responses microbial involved in intravascular thrombosis. Also, you are going to have intravascular thrombosis, and if there is not a regulation of that intravascular thrombosis during infection, you're going to suffer from a disseminated intravascular coagulopathy. So the next one now is the organ dysfunction. If you have a widespread endothelial injury, so you need to know that when you have an infection, you're going to have endothelial injury, and that endothelial injury can result to thrombosis. So provided that you have endothelial injury and thrombosis to an organ, you may have organ dysfunction, and if it is a multiple organ, you are going to have multi-organ dysfunction. The next one is septic shock is characterized by compromised oxygen delivery to the tissue. Now, what is the clinical feature? What are the clinical feature of a patient that has sepsis? A patient having sepsis is going to have hyperventilation, and hyperventilation is going to produce now a respiratory alkalosis. A patient having sepsis, that's provided the patient also have even septic shock, is also going to have encephalopathy, disorientation and confusion. He's going to have aqueous cyanosis, ischemic necrosis. You're going to have skin. On the skin you have hemorrhagic lesions. So these lesions are vasculitic lesions, meaning that there is inflammation inside the blood vessels. So we are going to have lesions, bullae, cellulitis, pustules. Skin lesion may suggest specific pathogens, example petechiae and purpura make you think of Neisseria meningitis, and ecdyma gangrenosum may make you think of Pseudomonas aeruginosa. Example, what are petechiae? So petechiae are minor bleeds underneath the skin which are less than 1 centimeter, and purpura are minor bleeds underneath the skin which are between 1 to 2 centimeters. Now on GI abnormalities, you're going to have nausea, vomiting, diarrhea. You're going to have ileus, meaning it's paralytic ileus, and you have cholestatic jaundice. So what are the complications that you may have in case of septic shock? You may have cardiopulmonary manifestation. So in cardiopulmonary manifestation, you have a ventilation perfusion mismatch, meaning that what you need to know that what in a sepsis you have an increased capillary permeability. We have already seen that before in the pathophysiology. So that increase is going to cause increased water content, and you have increased proteins that are going to diffuse into the alveolar membrane. So we have pulmonary compliance, oxygen leads, so proteins are going to these inflammatory products are going to extravasate, odds are going to extravasate into the alveolar membrane, and it's going to now result in acute respiratory distress syndrome. So that's the problem. Now, in case of the cardiac system, you're going to have hypotension, normal or increased cardiac output, and decreased systemic vascular resistance. Now, ejection fraction is going to be reduced due to also ventricular dilation. In cases of, you need to know that these cytokines in inflammatory products such as prostaglandins are going to result in dilation of many structures systematically. So you're also going to have ventricular dilations, allow maintenance of the normal stroke volume. Now, the next one that we are going to have now is adrenal insufficiency. So adrenal insufficiency can also occur in septic shock. So it may be difficult to diagnose in critically ill patients. So at the beginning, you may not see adrenal insufficiency, but you need to know that it may occur also as another cause, or as a constellation in multi-organ dysfunction. The third thing, we have renal manifestation. Also, a patient who has a problem may have problems like corticosteroid secretion, aldosterone secretion, and fluid and water regulation just because of sepsis. The next thing is a renal manifestation. In renal manifestation, you're going to have oliguria, or you can have polyuria. But it's mostly oliguria because the patient may have an acute kidney injury. You have azotemia because the patient may have an acute kidney injury. The patient may also have proteinuria. Proteinuria in case where you have infiltration of vasodilation and fluid and protein infiltration inside the kidney. You have renal failure due to acute tubular necrosis, ischemic. So due to ischemic acute tubular necrosis is very common. You have neurologic manifestation. For neurologic manifestation of this, it may present as delirium. So a patient is going to have delirium in acute phases. You have polyneuropathy with distal motor weakness with sepsis. So polyneuropathy can also occur with distal motor illness with sepsis. Are you getting? You have also cognitive impairment. You have immunosuppression. Patient may have reactive herpes simplex virus, cytomegalovirus, and varicella zoster virus. Now, what are the laboratory findings that you ask? So every time that you want to make your diagnosis, you need to put your diagnosis in a supportive and then a confirmative manner. So to support your sepsis, the first thing you have to do is leukocytosis in blood vessels. It's going to show you left shift. I also have thrombocytopenia. Why? Because you have endovascular injury, and then most of the the platelets, which are called thrombocytes, are going to be used in producing those blood clots. So you're going to have thrombocytopenia. You have excessive coagulation. So if there is excessive coagulation, now there is going to be prolonged thrombothrombin time. You are going to have decreased fibrinogen. You are going to have the presence of D-dimers because there is excessive coagulation, there is excessive breakdown. Presence of D-dimer is going to be suggestive of disseminated intravascular coagulopathy. With disseminated intravascular coagulopathy, the platelet count fall less than 50,000. You have now chemistry. So for the chemistry, you have metabolic acidosis, elevated anion gap, and we have the liver function test may also be high because as a consideration of the complications of septic shock, you also have liver failure because of the infiltration of these proteins also, or inflammatory products inside the liver. So how do you make a diagnosis? Definitive diagnosis requires the isolation of the microorganism in blood. So you have just to do blood culture, or you have to isolate the microorganism in blood. Now you have sepsis and septic shock. So how do you manage this patient with septic and septic shock? Are you getting? So you need to know that one. You have antibiotic treatment is very required. So we are going to have removal and drainage of the focal source of. So you need to know that what every time you want to treat a patient with infection, you need to know the principle of management of every patient with infection is. So, just the principle of management of all patients is: number one is to relieve the symptom by treating the disease. Number two is by treating the cause. Number three is by preventing and treating the complication. Number four is by preventing the reoccurrence. And number five is the follow-up. So, when you want to manage now, the principle of management of an infection is always by number one, removing the primary foci of the infection, and number two is by treating the systemic disease. So the primary foci, that's why they are telling you removal or drainage of the focal source of the infection. Example: if you have an indwelling catheter, which is the source, you have to remove. The Foley catheter, which is the source, you have to remove it. If you have sinusitis, you have to drain the sinuses. If you have the chest X-ray with an abscess, you have to drain the abscess. So this is very important. Now, if now you have for the antibiotic therapy is going to help you in the systemic management of the infection, and the last one now is to treat the specific complication caused by the sepsis. So now, if you have hemodynamic, respiratory, and metabolic unit disorders, you are going to need this support to help you. Now you have initiate the treatment with 1 to 2 liters of normal saline over 1 hour. So if you have septic shock, we start with 1 to 2 liters of normal saline, that's a crystalloid, over 1 to 2 hours to keeping the central venous pressure between 8 to 12 centimeters of water. Now the urine output should be greater than 0.5 mils per kilogram per hour, and the mid arterial blood pressure should be greater than 65 millimeters of mercury. You can add vasopressors if you need. If hypotension does not respond to fluid, so if you have hypotensive patient but it does not respond to fluid, you need to use hydrocortisone. Because in this case, because you may give the fluid to the patient, but the patient is always losing the fluid by polyuria, it means that the patient has had which type of complication? It's going to have the adrenal insufficiency complication. Since the patient had the adrenal insufficiency complication, you need to do hydrocortisone or fluorocortisone replacement. So that's it. So if clinical improvement now result within 24 to 48 hours, most experts will continue hydrocortisone for 5 to 7 days. Now, maintain oxygenation. So oxygenation is going to be required if you have an acute respiratory distress syndrome as being your complication. So you have to do it, and then you provide your plateau pressure to be less than 30 centimeters of water to prevent injury to the. So typically you give 6 mils per kilogram of the body of oxygen. So that's the way you give, and you have to maintain that it should be less than 30 centimeters of water as the plateau pressure to prevent the further lung injury. Now we have erythrocyte transfusion is recommended when the blood HB decreases because you have anemia in sepsis, since the iron stores of the body is going to be much more stored. Free iron is going to be much more stored in order to prevent it from the usage with bacteria. Now, as general support, we have nutritional supplementation should be given to the patients with prolonged sepsis lasting 2 to 3 days with available evidence suggesting of delivery route. Now, prognosis, you need to know that 20 to 35% of patients with severe sepsis and 40 to 60% of septic shock die within 30 days. So it's a very poor prognosis. So 20 to 35% of severe sepsis. Severe sepsis means that there's already one organ damage, and 4 to 6% of patients with septic shock are going to die within 30 to 30 days, and further death within 6 months. Is it clear? Now, we need to know that prognostic stratification. So you have prognostics. So if you want to know the prognosis of a sepsis in a patient, you use your Apache 2 score. So the prognosis of a patient, you use the Apache 2 score, so can estimate the risk of dying of severe sepsis. So the Apache 2 can help you estimate the risk of dying in cases of severe sepsis. Now, what are the initial antimicrobial therapy that you can use? You have different regimen in case of sepsis. So if you have an immunocompetent patient, the first thing that you can use in case of sepsis is piperacillin tazobactam. So if you have a patient having sepsis, the first regimen I can use is piperacillin tazobactam. Piperacillin is an anti-pseudomonal penicillin. Tazobactam is a monobactam. I use both of them. Or I can use imipenem, cilastatin. I can use ertapenem, or I can use meropenem. The third thing I can use a third generation cephalosporin. Imipenem is a carbapenem. Third cifepim is a third generation cephalosporin. I can use it. So if patient is allergic to beta-lactam, use ciprofloxacin. So a third generation cephalosporin may easily be replaced by a fluoroquinolone such as ciprofloxacin and levofloxacin. So plus a clindamycin. So use a clindamycin is going to target now anaerobes. Vancomycin should be added to each of the above regimen, because among the causes of sepsis we also have Staphylococcus aureus. So now the next one is, if you have now a patient that has neutropenia, you use now this regimen here. If you have a patient that has splenectomy, use this regimen. A patient that IV drug user, use this regimen. AIDS patient, use this regimen. The next one is prevention. Nosocomial infection cause most episodes of severe sepsis and severe shock in the United States. So nosocomial, the one that's taken from the hospital. Measure to reduce those infections could reduce the incidence of sepsis. So the next thing that you're going to visualize is going to be acute pulmonary edema. Thanks for your kind attention.